If you've ever wondered what a typical ethics consultation looks like, I'm going to tell you. So I'm a physician and an ethicist. I teach in Geneva, and I'm also the ethics consultant on our clinical ethics consultation service. If you ask clinical ethicists what they do, they will tell you there are differences in approaches to clinical ethics consultation. But if you take a step back and look from outside, we all do rather similar things. Where I work, a typical consultation begins with either an email or a phone call to the secretary of the clinical ethics consultation service. The person will describe why they're calling, what the difficulty is that they are having to face, and this description may or may not include all the relevant information that we need in order to do the consultation. So we then call them back and ask a bunch of questions. Talk with them to help them formulate what the difficulty actually seems to be. Then we organize a meeting. For those making the request, this meeting has to include as much as possible everyone who's actively involved in the care of the patient, during whose care the ethical difficulty is arising. They also have to tell the patient that the consultation is ongoing, and we normally go see the patient unless they don't want to see us. It has never happened yet, but they're allowed, of course, to refuse to see us. And also unless it seems that there is a good reason to not see the patient. This is truly exceptional, but it does happen. And even in those cases, we tell the patient that the consultation is ongoing, and if they want to see us, we will see them, despite the fact that we started out thinking that there was a good reason not to in that case. In most cases, it's straightforwardly a good idea to see the patient. We sometimes see family members as well, especially if the patient is not capable of making their own decisions. On our end, the consultation team has to include at least 3 people from different professional backgrounds, and at least some have to have experience. We have turnover in the ethics committee. Some new people come in, some people are more experienced. We will not send in a team with only beginners. And then we hold the meeting. During the meeting, we start by talking with the team, but actually we start by talking with whoever has asked us to come. Patients also have the right to ask us to come, and when they do, it's rare, it happens, but when they do, we see them first. But usually the teams ask us to come, so we see the teams first, and we go through one of several moral deliberation methods with specific steps to help us see all the different issues and think through all the different values involved in the case so that we can then give better advice. Moral deliberation has tools, it can be learned, it's a skill, it's one of the skills we're going through in my subscription space. So we go through one of those different approaches. There are several ones, and an ethics consultation service will usually use more than one. Not in each consultation, but they will have more than one at their disposal in order to use whichever one seems best matched to the situation. Then we see the patient. We do not send everyone in the group to see the patient. That's too many people. We don't want to overwhelm patients. And we don't even send everyone on the ethics consult team to see the patient, because even there we could be too many. We don't want to send 4 or 5 people. We're often 4 or 5 to see just one person. So we send in 2 people. Why do we send in 2 and not just 1? Because if you have a talk with someone, the potential for misunderstandings is always there. If there's 2 people, the risk goes down, because after you've had the discussion, the 2 can compare notes and see if they understood the same thing or not, and possibly even go back and check with the patients when they're not sure what the right interpretation was. Then we have a time where the ethics team will talk, discuss everything that we've heard, discuss everything that came up in the different steps of the deliberation, and decide what advice to give the requester. Then we call the team back in, we give them our advice, and that day, or at the latest the next morning, we make a summary of the advice, just a bullet point list kind of summary of the advice in an email form, so they have something in writing. Because then we send in a consultation report, which is much more thorough, with often references and a much more developed set of arguments. And that longer report takes a longer time to be ready. And we don't want the teams to have to make a decision based on verbal advice only. The written report is a part of the patient's file. This means every patient for whom an ethics consultation has been requested has access to the written report. They can read it if they want, and we tell the patients that. So a typical ethics consultation is a bunch of people talking in a bunch of different steps. It does take some time, but this is actually an investment of time, because if you don't invest the time for a moral deliberation, the time it will take you to navigate the situation without having resolved it will usually be a lot more than that. Yeah.